Hello and welcome to this new podcast of the American Journal of Public Health. With my dear co-host, Vickie Mays, we today have two great hosts. Uh, First of all, Dean Sherry Gleed from Wagner, New York University. Hello, Sherry.
Hi.
Great to have you.
Always fun to do this.
And then we have Stephen Wolf, the author of the article that you see just behind me about COVID-19 excess overall mortality across US states. Steve, welcome.
Pleasure to be here.
And remind us, what's your current situation in Virginia?
Well, I'm a professor of family medicine at Virginia Commonwealth University and director emeritus of the Center on Society and Health at VCU.
Thank you. So let's go right away into this conversation. In this analysis that Steve did, they used, according to the journal, the correct outcome to measure the impact of COVID-19 on the US population, which is the excess global mortality compared to what would have been expected during those years in each of those states. We have been always reluctant to publish data that were COVID-19 specific because of the differences in diagnosis and access to tests across the country. And so we believe that this analysis has the correct outcome, and it has some extremely interesting results. So Steve, can you briefly summarize what are the main observations of your study?
Well, again, using the excess deaths as a basis for judging the impact of the pandemic, we looked at the period from the onset of the pandemic in March of 2020 all the way through to July 2023 and found that almost 1.3 million excess deaths occurred in the United States during that overall period. About 90% of those deaths were attributed to COVID-19, and about half occurred after vaccines were available. We calculated the excess death rate, which is taking account of population size, and that enabled us to compare the excess death rate across the 50 states. This allowed us to see which states were more severely impacted by the COVID-19 pandemic than others from 2020 to 23. The states that had the highest excess death rates were West Virginia, New Mexico, Mississippi, South Carolina, Wyoming, Louisiana, Arizona, Kentucky, Arkansas, and Alabama. And that's interesting because if you remember at the beginning of the pandemic, the states that were most severely impacted were in the Northeast, New York, New Jersey, Massachusetts, and especially New York and New Jersey had catastrophic losses from COVID-19 at the beginning. So if you look at that initial phase, that's the part of the country where we saw the biggest impact at the onset of the pandemic. But our analysis looked at different phases of the pandemic, 5 of them, and found that that early phase had very different regional patterns in terms of which states were affected. And also, we did something a little interesting in this analysis to look at the partisan orientation of the states to see whether there was any association between whether you had Democratic or Republican governors or the degree of Republican representation in the legislature, whether those partisan orientations had any association with the excess death rate.
And so, Sherry, what's your first reaction to those findings?
So, I think it is such an interesting question, and it's been such a politically salient question. People are, all these governors are campaigning and saying that they did a great job on COVID or they did a terrible job on COVID. And so it's good to have some data to actually put to the question. And I think it's really interesting also, the pattern was not the same in all 5 phases. And what public health was actually doing, if we think of it that way, or what was called upon people to do was different in all 5 phases. And I think there's a lot that we can eventually learn from trying to parse that and see what's going on. So I think it opens a great set of really interesting questions that, and I think you started off, Alfredo, by saying that you don't like to run pieces on COVID because it's such a one-off thing. God, let us hope, right? But I think this actually gets us to a question of like, well, what can we learn from this experience about the capabilities and the weaknesses of our public health system, our infrastructure, our political system? So this will be really useful as we move forward.
Talk about these phases, because this is where I think it's more not just about the disease, but how it does have phases and what things we should be doing differently in these phases.
I want to start out by sort of putting a pin in the fact that we were looking at partisan orientation, and politics is something that, at least in the way I was trained, is something we generally don't get into in scientific research. I was brought up, with the training that we should try to be nonpartisan and objective. But what happened during the COVID-19 pandemic, and I think we're still seeing it post-pandemic in regard to other health policies, is that, first of all, states took a very dominant role in setting policy in terms of public health policy, and partisan orientation became a determinant of what those policy choices were. So if the governor had a D or an R after his or her name, you could predict pretty accurately how they were going to go about approaching the COVID-19 pandemic. So it became, in our view, an appropriate epidemiologic question to ask, whether there is a difference between the partisan orientation. I do want to get to the caveats and potential confounding variables that need to be thought about when we look at these associations, but I think it's an important question, especially as we go forward in time and we're debating decisions that states are making about reproductive health rights and a variety of other policies that have huge health outcomes and also seem to be splitting along partisan lines. Now, to your question, Vickie, we thought it was very important to divide this analysis up by phase, because things were, as you said, very different during each of those periods. And an analysis that sort of throws the whole thing into one big bucket fails to capture those nuances. So the first phase was the initial outbreak of the pandemic. This is the period roughly between March and June of 2020. This was a period, as you'll recall, where we were just learning what kind of disease we were dealing with and trying to figure out what kind of pandemic control policies should be implemented. The next phase that we looked at is what we called the pre-vaccine period, phase 2, which is the period during which we did not yet have a vaccine and were very reliant on pandemic control measures such as social distancing, preventing large social gatherings, and so forth. And this was the period where things started getting very political. There was, as you recall, a debate about how quickly to end the lockdowns and open up businesses. States with more conservative orientations tended to open earlier. And there was also, going forward, a difference in attitudes about mandates and prohibitions against activities that would increase transmission of the disease. So states with certain orientations were more likely to lean forward into that and really have strong mandates, whereas others were resistant. And in some states, governors overturned the decisions of local local governments, such as mayors and county councils, to prevent those cities from enforcing stricter pandemic control measures. So we wanted to see what that pattern looked like. Then in phase 3 is the beginning of the vaccine period, the period during which the vaccine was rolled out. And we saw very interesting differences in how quickly the populations of different states were immunized against COVID-19. There are 2 additional phases that we looked at, phase 4 and phase 5, which were the less active periods where COVID-19 mortality rates were already dropping. But we wanted to see whether during that period, this is after vaccination rates were starting to stabilize across the states, whether there was much of a difference. But phase 2 and phase 3, this is the period roughly between June of 2020 and March of 2022 was where the vast majority of the deaths occurred from COVID-19. And that's where our analysis was most concentrated.
Sherry, I want to also say that there are some economists who did similar studies, compare Republicans and Democrats. They were cohort studies in which, the political affiliation was defined on the basis of electoral, registration, and the people were followed individually. And they showed the same thing.
Yeah.
Over mortality.
Yeah. So I think one of the interesting questions that we need to explore more in Stephen's study also, the thing about COVID is that on some level, if you were just willing to lock yourself into your house or apartment or your room, whatever your state did, you could protect yourself from COVID, right? Your own actions were facilitated by the state, but not determined by the state. And that means that individuals within states can also behave in different ways. So there has been some analysis using individual voter registration records, for example, there's a paper looking at Florida and Ohio, for example, and showing that Republicans within those states, within those regimes, have higher rates. I think there are a couple of, again, this is just such a fascinating area, but so one question is, to what extent is the behavior of the government, or is the constitution of the government, simply a reflection of the people who live in it, right? The folks in South Carolina are Republicans, and the folks in Texas, they're, people who think that the government shouldn't interfere in anything you do, and they're skeptical of government. And so they vote in Republican governors who are skeptical of government. And sorting out whether, for example, the governor of Texas could have, even if he had chosen to, effectively enforced public health restrictions that would have reduced the spread of the pandemic is a question that I think we don't know the answer to, right? So what we might hope for from public health in this situation is that public health reduces naturally occurring inequities. So I gave this example that said, if you just wanted to stay home, you wouldn't get sick. I had relatives who didn't leave the house for 9 months, right? That you had to live in certain circumstances to be able to do that, though. And there are some people who could not do that. So we might, in a further exploration of this, for example, say, were the differences among low-income people bigger or smaller between low-income and high-income people, bigger or smaller in states where public health behaved in different ways? Because that's, to me, that's the vehicle that where public health matters here. It's not, in some sense, unlike the reproductive health situation, where it's an individual behavior and the state might prohibit you from acting. Here, right, you could take precautions if you had the means to do so no matter what, and you could probably expose yourself if you had the means to do so no matter what, if that was your particular gig, right? And so in some way, what public health really does here is perhaps, and we have to look at it more, perhaps create more equity.
The issue of the trust of the information you're receiving, and whether you take it from public health or you take it from government officials. One of the things that I think we struggle with is, particularly if we were to look at people with differences in education, we're seeing now in terms of bird flu, people don't know who to believe in terms of bird flu. And so public health is one thing, and then the government, I think, the governor and others, is another. So how does public health put itself in a position that no matter who governs, that its words are taken as either trustful or not?
Yeah, this is a larger societal problem that we have right now, is that we're living in different information ecosystems. And so there are certain populations that are more predisposed to trust what guidance they get from public health and governmental authorities, and others that, even setting aside the people with conspiracy theories, there are many others who are much more skeptical about the validity of the information that they're getting. And, the foundation of what constitutes facts is not something that everybody's in agreement on. I wanted to come back to what Sherry was saying to sort of expand a bit more about how complicated this is. So one problem with the hypothesis that the excess deaths rates reflect policy choices made by political officials is something that Sherry raised, that this may actually have something to do with the behavior of the people that live in those states and that elect those officials, and that they may have certain tendencies in terms of how they handled the pandemic that affected their outcomes. But even if you go back in time before the pandemic, there has been a body of research going back about 20 years or so now that has looked at differences in mortality rates and other health outcomes among populations that, for example, among counties that have voted for Republican or Democratic presidential candidates, and other kinds of analyses that have looked at partisan orientation. And pretty consistently, at least in the last 20 years or so, have shown higher mortality rates, higher rates of premature mortality in populations that vote Republican and in Republican states, red states, etc. But we obviously recognize the importance of the social determinants of health, so it's very important to think about what is the poverty rate, the median household income, the educational attainment that exists in those populations. Also, and the answer, of course, is that for many of them, the populations experience lower socioeconomic status and are therefore at greater risk of disease and death for that reason. And they also have higher rates of comorbidities, which all of these ended up being potential risk factors in terms of COVID-19 hospitalization and mortality. So another layer of complexity in understanding this analysis is how much of this has to do with predisposing characteristics, baseline characteristics that existed as the states rolled into this pandemic and were more vulnerable because of the condition of their population. But then you can take it one more step and ask, well, is the socioeconomic condition of their population also a reflection of policy choices that have been made by state government? Things like minimum wage, earned income tax credit, tobacco taxes, and a variety of other policies that are set at the state level are handled very differently based on the partisan orientation of the government. So some of those confounding variables may themselves be products of policy choices as much as baseline predictors of health outcomes. So our article tries to get into this complicated mess simply to say that we have a lot more research to do to tease out how much of this is due to what struck us as investigators as the major hypothesis of the study, that the policy choices the governors and legislatures were making inflated the excess death rate of those states.
Is the government a reflection of the people who live in the state, or are the outcomes of the state a reflection of the government, right? Is public health part of the government, or does public health sit outside of the government as an independent voice, which structurally it does not, right? So the fact that people think of public health and the government together is not insane of them. Public health is a branch of the government in some formal way, but how do we is that a thing that we want to or could even imagine disentangling so that people would feel confidence in public health even if they disagreed, say, with their local government, or if public health disagreed with the government? Can we imagine a world where the public health authorities contradict the governor? That's a hard, right? That's a hard one to envision as well. This is in no way a critique of Stephen's paper, which I think is very, very helpful. I think as we try to figure out where we take it, it is this sort of layered nature of the political environment. And as Stephen says, everything, the pre-existing conditions also reflect the choices made by the government. And those choices presumably are done to get the government elected. So they also are based on people's views. And so, we could spiral all the way to nothing, which I don't think we want to do, but it is a really complex challenge.
Yeah, but Republican has paid really the higher price in terms of mortality after the introduction, in particular, of the vaccine. So,
yes.
Is there no accountability for those deaths who were preventable?
So I think you might be thinking about it wrong, because I don't want to say that, you're the editor, but I'm not. So first of all, there has been no accountability for those deaths. The answer is no governors, as far as I can tell, have lost their seats because mortality rates in their states were really high. Kristi Noem, who caused a catastrophe at some point in South Dakota, right? With the biker rallies in the middle of COVID, was going to run for president before she killed her dog. There is no sense among the voters in those states that their governors behaved incorrectly. And part of that may have to do, so part of that, I think they're, again, sorting things out. Part of that is no states are monolithic, and there are surely, and unfortunately, the brunt of mortality was borne by people of lower socioeconomic status and disadvantaged people and minority populations, because minoritized populations, because that's always what happens. So that's item one. Item two, I think in many of these states, they would say, higher mortality is the price we paid for more liberty, and that's a price we were willing to pay, and that was the deal we made, and we took it. Which is why I think the most interesting questions really have to do with who within the states suffered more because of government decisions. That's really like, you are a high SES person who doesn't care. Go ahead, make my day, be free and live free and die, whatever you want. But what do we do? How are we providing protection to the more vulnerable amongst us? And that's perhaps the government role here. Once the information is out there, I don't stop people from doing all kinds of crazy things, right?
I would say there's been no accountability yet, because in order to say what they said about the vaccine and the campaign, they had to go off what the science said. They had to actually refuse to follow the evidence. And and in some ways, they confused their population and they oriented them to do things that were bad for their health. Maybe they were not aware of it. So
you're more optimistic. I don't think that there will be any reckoning. I really, on the contrary, right? I think they're busy. In fact, if anything, the reckoning has gone the other way. We kept the schools open. We didn't make you lock up. That's been a very successful point, not.
Well, what's very important, I think, about this kind of research and getting it out into the public is sort of try to expose, to a certain degree, the fact that there are health consequences of these policy choices. And it would be nice if it was a one-off, something historical with the COVID-19 pandemic that we don't need to think about again. But, right now we see tangible outcomes for women based on the reproductive health policies that states have adopted. We see consequences related to firearm-related injuries because of state policy choices that are being made. And at some point, I think we need to raise the public discourse about the price we're paying in terms of our health and the health of our children because of these policy decisions that are being made at the state level.
There's some for whom their privilege allows them to exercise their rights. So there are people who refuse vaccines because they believe it was their right to do that. Where I think public health and the government has a greater responsibility is in social vulnerability. We started to use this concept of social vulnerability in the epidemic, but what we haven't done is to determine a specific set of responsibilities. We used it to, push out the vaccine. We used it to identify, reimbursement and all the things that we needed to take care of that population. But we didn't build in a responsibility and accountability kind of quotient to that. Once you get identified as socially vulnerable, what is the responsibility? We do that in terms of things like people who are 65 and over. We have a set of ways to do that, but we haven't done it yet. And to me, any deaths that occur as a result of the current version of COVID are unacceptable because they were preventable. But we're not focusing on those with the most social vulnerability likely to have the greatest death. We instead are focusing on kind of the aspect of getting the vaccines out, communicating, but yet ignoring who it is that's the most at risk.
You see, it's an absolutely fabulous conversation, and we should continue it, but we're reaching the end of this podcast. And we raised so many questions, fascinating questions. I think, Vickie, we need to continue this another time with more specific discussion. Thank you very
Thank you
much.
very much.
Thank you, Sherry,
Bye.
for coming. Thank you, Steve, for your great work. And thank you for listening to our listeners. Okay, bye-bye, everybody.